Thank you for the kind invitation, and it's an honor of being here. I'd like to share with you my experience with stem cell in Israel, which is kind of a new thing. First, I'd like to take you to Haifa, where I live, where the hospital is. And this is a base city. This is the hospital overlooking the bay and the Baha'i Garden, and that's how it looks, much more sunny and nice. So my unit is a unit with 7 senior physicians in rheumatology, and we have very long-standing and warm relations with France. We host the France-Israel Symposium for 20 years now. Next month will be the 20th. And 5 years ago, Dominique was our distinguished guest, and she shared with us her knowledge and vast experience with stem cell transplantations in systemic sclerosis, and I was very enthusiastic about that. It was not 4 months after that when a 64-year-old lady with short disease was admitted to our ward. She was a severe patient with rodent skin of 33 after 4 months. She had digital ulcers, a very typical capillaroscopy, and severe gastroesophageal reflux disease. She had a mild pulmonary fibrosis with reduced DLCO and a normal echocardiography. She was SCL70 positive, and we treated her as we treat, and in those days, most patients with cyclophosphamide, which was then the standard of treatment with Nexium and Iloprost. But her lungs went and worsened, and her skin also. And in that point, I contacted Dominique and also Professor Zila Zuckerman, who is the head of stem cell department in my neighboring hospital, which is Rambam. And at that point in Israel, as you can see, there were absolutely no stem cell transplantation in systemic sclerosis, only old cases in MS in Hadassah that were now not being done anymore. And I talked to Professor Nagler, who was the head of the Israeli BMT, and asked him what his opinion and his experience, and he just answered 30 years of heartbreak. So I went on anyway, and we had a cardiac MRI, a right heart cath, which was okay. We wrote 2,000 letters to authorities, but it was approved at last. And we had the protocols from MATHEC with kind help of Dominique. We had a mobilization with GCSF and intensification. And it went okay, but we had some difficulties. She had Aspergillus pneumonia, and then she had the late cytotoxicity of cytoxan and ejection fraction of 20%. But it all resolved with time and treatment, and she went into our rehabilitation center. She was doing good work. Her lungs were getting better and better with an FVC of 95%. She was feeling good. She gained weight. Her rodent skin score was better, going down to 20, not enough, but looks nice. And she was very happy with that. She didn't want any more treatments. But it didn't last long. And we were looking at her immune system using CyTOF, which is a technology that marks specific antibodies within a cell by their mass, by elements that has different mass, not by wavelengths as flow cytometry, which enables us to mark more than 50 elements on the same cell. And we have a good look at the immune system, and that's how it looks in that lady case. So we were following that, and unfortunately, it was looking that her Tregs were going down, her CD8 were going up and up. She had SCL70 titer was going up, and she had a relapse 22 months after AHSCT. So she was treated with rituximab and Cellcept, and she was stabilized, but not very good. But the road to success is not a straight line, or as Winston Churchill said it better, success consists of going from failure to failure without losing enthusiasm, and I didn't lose that. So second patient was much better. She was a bit younger, a 58-year-old lady with a high Rodnan skin score, RNA polymerase 3 positive. She had terrible lung. And I was already contemplating stem cell, but giving her CellCept as was typical at that time. She worsened, and she had an FVC of 65 and DLCO 59 when we went to stem cell. All the workup was okay, and this time it goes smoothly. No complication other than fever through the aplasia time. Rodnan skin score went quickly to 4. And she had a seroconversion of her ANA, and her FVC was going better and better, up to 99, DLCO 83, so we were very happy with that. And going on and further pursuing stem cells. At that point, in a more organized way, I joined the MATHEC meeting with RCP, presenting our patients. And 2 months ago, we finished the 6th patient. You can see patients are pretty young. The youngest was a child, 12 years old, who had an overlap of systemic sclerosis and dermatomyositis. Most patients were AHSCT or RNA polymerase 3. And we treated first before stem cell with cyclophosphamide, went to CellCept, MMF, and now we're using MMF and rituximab. The mobilization was only with GCSF in Israel. We did not use CD34 selection, mostly due to economical problems. But we had nice results. We have minus 16 in the MRSS overall, plus 22 in the FVC, and plus 6 in the DLCO, which is pretty looking like the literature. We did have complications. We said aspergillus pneumonia, late cytokine toxicity, renal crisis, and capillary leak syndrome, or ATG-related phenomena. But overall, all patients are alive. We have 60% seroconversions and only 1 relapse, and patients are doing good and feeling happy with good quality of life. Last patient was already included in the new NISCC2 study, and we hope to proceed on with that. Finally, this suit of stem cell transplant is not fitting everyone. And some patients cannot go through because of bad heart condition, lung condition, or just personal preferences. And in that case, I want to share with you what I'm doing right now is using, in this very progressive systemic sclerosis patient, an upfront combination therapy that is directed at the vascular, the immune, and the fibrotic system. Iloprost for the vascular, blocking B and T cells with rituximab and CellCept, and when I can, lenabasum, which is a cannabinoid 2 receptor agonist, which is a good anti-fibrotic agent that is gaining understanding and experience in systemic sclerosis. So overall, in the last year, 10 patients, mean age is 44, half of them AHSCT, half of them RNA polymerase 3. Positive, they are MRSS is 23, FVC 66, so these are pretty serious patients. And you can see that the combination therapy, and I'm trying to have an historical control without trying to do statistics, just the crude numbers. You remember the SLS2 study, which used MMF and is a gold standard in rheumatology and systemic sclerosis. So you see Rodnan skin score went by minus 14, while in SLS is minus 5. The FVC is up by 7.4 in the SLS 2.8, and DLCO is up by 7 in the SLS minus 2. So it seems, at least the crude number is better to use upfront combination therapy in these very progressive patients. In conclusion, it seems stem cell transplant in systemic sclerosis is a game-changing therapy. I hope we gain a new block, a blue block in Israel in the next review. And it all has been possible due to the warm Israeli-France relations, and specifically I thank Dominique and MATHEC, all the other staff of MATHEC that has enabled disseminating and implementing this new technique in Israel. And as Humphrey Bogart said it much better, I think it is a beginning of a beautiful friendship. And I thank you all from Haifa, Israel.